So we've got 3 speakers, and then after that we have another coffee break. The coffee break will be in the bar region. I've been asked to mention that the Archive Centre have put together a small exhibition just outside the lecture theatre called Skeletons in the Library. And essentially it is some photos and information about the skeletons that are held within the Churchill Library that the medics, and I'm sure some of you have even used whilst you were learning anatomy during the 1st and 2nd years. So the next speaker, Dr. Hannah Jacob, matriculated in 2003, currently a registrar in Pediatrics in London, and she's going to give a talk that's titled Not So Tall Stories, Tales from the Front Line Child Health in the UK.
So thanks very much, and thank you for the invitation. My name's Hannah Jacob. I'm a paediatric registrar on the North London rotation, and I would like to tell you a little bit about what life's like as a clinician. And I make no apology for this being directed primarily at the current undergraduate students. And echoing some of the people from this morning, I would just encourage you to well, first of all, to stick with it even when it's really tough, and secondly, to think about how broad your options are at this point, because we've heard from some very eminent people doing lots of really impressive research, and I suppose I see my role as slightly providing a counter-narrative to that about what you can do primarily as a clinician. Okay, so this is where I work. This is North Middlesex Hospital, which is in North London. This is the image that they would like to show you on their website. This is what it actually looks like. Which pretty much sums up the whole place. For those of you not familiar, this is a hospital, so a district general hospital, very big and busy district general hospital. Certainly the A&E department is the busiest in London, and I think the children's A&E is the 2nd busiest in the UK. It straddles, so it's right next to the North Circular, which is a massive dual carriageway, but it also serves a very deprived and very mixed population, which I'll just tell you a little bit about. Around a third of this is ONS data from the most recent census. The hospital covers both Haringey and Enfield, which are 2 actually very diverse and also very deprived boroughs, particularly Haringey. A third of the population of Haringey is under 20, and you can see that that's predicted to continue. At the most recent census, 65% of the population of Haringey were non-white British, and it's a huge spectrum of cultures, of languages, of religions, which makes for really exciting and really interesting work. But just by way of context, in terms of the families that we're seeing and where people have come from. Haringey is the 6th most deprived borough in London, and I think ranks 13 out of about 300 local authorities in the UK in terms of most measures of deprivation. This is just, again, a bit of context. So this is some work done by Ingrid Wolf, who is a paediatrician turned public health physician. This was published in 2011 in the British Medical Journal. So this is all-cause mortality for 0 to 14-year-olds in a number of European countries, including the UK. You'll see that overall, all-cause mortality has fallen, as you'd hope, since the 80s. But actually, that black line is the UK, and you can see that actually relative to pretty much all of our European colleagues, we're actually doing less well on all-cause mortality for children. And I think that's really important just to bear in mind when I go through a little bit about my day job. So what I thought I'd do is just give you, so I worked last weekend and I worked the nights the week before, and I'm not going to lie and tell you that I'd planned this presentation very far in advance. So this is basically a collection of 10 children, I'm going to tell you about 10 children who I saw over the course of those the last couple of weeks on call, I guess to give you a flavour, but also to try and speak to each of the topics and broad topics that you cover in your 1st and 2nd year, just to show you that actually what you're learning is relevant and can be applied in a clinical way. So the first one, this was nights last weekend. So the obstetric registrar called me. I was covering neonates, because if you're a paediatrician, you cover 0 to 16. So I was the registrar covering the neonatal unit, and the obstetric reg phoned me. Never a great call to have at 4 o'clock in the morning. And he said, oh, we've got a woman, she's just come into maternity triage. She's 29 weeks pregnant, so a normal pregnancy is 40 weeks, so 29 weeks is really quite premature. She had a baby before, so this was likely to be fast. She's come in, she's contracting, and I've just examined her and she's fully dilated. I said, okay, how long have we got? He said, probably about half an hour. So we went round to the labour ward and we got things set up. And for those of you who have recently done your physiology and also your reproduction, you'll remember that those type 2 pneumocytes aren't too active at 29 weeks, okay? So this child was not going to have any surfactant effectively in their lungs. And this is an X-ray, not actually of this baby, but it looked pretty similar. So this baby was born within the next 20 minutes. The woman had had no antenatal steroids, so we ordinarily give, if we know that we're expecting a preterm delivery, we'll give steroids antenatally in an effort to get the lungs producing some surfactant endogenously. And when you don't get a chance to do that, and actually quite often even when you do, babies are born with respiratory distress syndrome, especially if they're very premature, and you intubate them. So I intubated this baby, and we gave surfactant, so artificial surfactant, down the tube into the lungs to try and reduce that surface tension so that these lungs are less stiff. Okay, same night, earlier in the night, it's quite busy at the North Mid. We'd had a crash bleep to A&E resus. So we went down there, 4-year-old girl came in, brought in by the London Ambulance Service. They call ahead if they've got children who are really sick so that we're all there ready. And this was a girl who had known asthma, who'd had a really short history of being quite wheezy for the last kind of 24 hours, and then overnight her mum had described her suddenly working really much harder at her breathing, not really improving with her salbutamol inhaler at home. And I put this up because I think this is quite a good example of pharmacology in action. So these are the British Thoracic Society guidelines for acute severe asthma in children over 1, and one of the things that's in the new guideline is about using inhaled magnesium in your nebulizer when you've got a child who's got acute severe asthma. This is a really exciting thing. This is something that actually there's now really good evidence for in children. And I guess this brings me to my next point about the application of evidence-based medicine. So we've heard quite a lot about the research that people are doing, and actually this is an example of research used really in clinical practice. So Colin Powell and co in Cardiff did a multi-centre randomised trial looking at children over 1 with acute, actually over 2, with acute severe asthma, and randomised them either to get normal treatment, which at the moment is salbutamol and ipratropium nebulised, or to get that plus inhaled magnesium. Now, for those of you who've never done a paediatric job, getting a line into a child can be really difficult, especially if they're ill and especially if they're frightened. And actually, if you're talking about doing a painful procedure in someone whose airway is potentially compromised, there is the risk that you tip them into respiratory failure, respiratory distress, and ultimately they stop breathing. So anything that we can do that's inhaled is obviously beneficial. They did a randomised trial, 500 children, which for those of you who've ever done any research with anyone, but especially with children, is massive, and showed a benefit of inhaled magnesium in children who are very hypoxic, so very low oxygen saturations when they arrive, who've got a short duration of illness. No one quite knows how it works, but it's clear from their data that it works better if you've got a short duration of illness, probably because that's driven by a neutrophilic process rather than the kind of subacute eosinophilic driven asthma. Okay, one of the other things that the North Middlesex is also well known for is Victoria Colombier and Baby P. So both came through the North Middlesex on a number of occasions actually, and you'll know that they're 2 high-profile children who died both in Haringey. So there's a mantra when you're a paediatric trainee, particularly trying to instill in the SHOs, a collapsed baby. It's either got to be sepsis, it's got to be metabolic, or it's got to be cardiac. Unfortunately, where I work, there's a number 4, which is non-accidental injury, and that's what this is a CT image of. So the week before, we'd had a 4-month-old come in with CPR ongoing with the London Ambulance Service. For those of you that work in adult medicine, I realise that's quite a common occurrence. That's really not very common in paediatrics. Children really don't have cardiac arrests. And CPR was ongoing. And what emerged fairly quickly as we began to resuscitate this child is that actually she'd had a major head injury, and this was non-accidental injury. So this is shaken baby syndrome. This child had a massive subdural, rising intracranial pressure. And I've put this in as an example, I guess, of neuroanatomy and also physiology in action. So this was a child that we had to nurse slightly head up because we're trying to reduce the pressure in their brain. We had to intubate this child so that we could finely tune the partial pressure of carbon dioxide that they were inhaling, and their blood levels of carbon dioxide, because we had to be really careful about the amount of blood that was going to this brain. We had to be careful about the amount of fluid that we were giving this child, and actually the child, at the point at which they left to go to a neurosurgical centre, the heart rate was starting to drop and the blood pressure was starting to rise, and that's a sign that child actually was coning. So that brain was literally starting to go through the foramen magnum. So this is neuroanatomy in action. The child actually managed to get to the neurosurgical centre, had a big bolt put in, and had survived. We don't know yet the long-term consequences of that. I'm working in the community as my day job at the moment. So community paediatrics is quite different. You're talking about lots of neurodevelopmental stuff, so children with delayed development, lots of children with autism, autistic spectrum disorder, ADHD, so attention deficit hyperactivity disorder, and also a lot of child protection. And in that same week, it's actually been quite a tough 2 weeks. I'd done child sexual abuse clinic, which is about as much fun as you can imagine. And I'm not going to dwell too much on the cases that I saw, but I thought perhaps to lighten the mood, I could show you a couple of videos produced by the NSPCC, I guess thinking about how we help to prevent things like this happening in the future. Oh no, is it going to work? Yes.
This is Pantosaurus. He's going to help us with our song about pants.
Pantosaurus, what's in your pants belongs only to you. Your pants cover up your private parts. Your private parts belong only to you. If someone asks to see, just tell them no. Pants, Pantosaurus, pants, Pantosaurus. Pantosaurus likes to wear his pants. He wears them all day long. They cover up his private parts, and that's what makes him strong. If someone asks to see or tries to touch him underneath them, he tells them no, then tells someone he trusts and likes to speak to. What's in your pants?
Okay, you get the general idea. So that's obviously aimed at children who are your little children and thinking, what's in your pants belongs only to you. That's quite a powerful message. The second one I'll show you is aimed at older children, as you'll see. Oh, hang on, sorry. Where is it? Oh, sorry. Here we go. F5. Okay.
One day, Alex and Sam were mucking around on their phones.
Why don't we take a selfie? Yeah.
Then Sam had an idea.
I'll take a picture.
What if they sent a picture of Alex's willy to their friend Katie? The kind that disappears in a few seconds.
Send.
When Katie saw it, she thought it was very funny. So she screen grabbed the picture and sent it to her friends. And they sent it to theirs. And the next day at school,
Newsflash! The world sees Alex's willy.
Alex even got a message from a bully. He then got one from a man he didn't know. Sometimes children share things they shouldn't online. And the effects can be devastating. Help keep your child safe. Be share aware.
Okay, so obviously I've included those as a bit to lighten the mood, but I think the point is serious, that actually, there's a lot of child sexual abuse, and from various high-profile cases that lots of historical allegations are emerging, and obviously prevention is better than cure. So one of the roles that I see for us as paediatricians and healthcare professionals working with children is thinking about how you empower them in a changing world around the use of social media and around the use of knowing their rights and knowing who they can contact for support in these situations. I'm aware that there are a few paediatricians in the audience. I don't think that any talk about pediatrics, particularly not in winter, would be complete without mentioning this bug. So this is respiratory syncytial virus, so this is RSV. As any of you who've ever done a paediatric placement will know, particularly over the winter months, this is the main causative organism in a condition called bronchiolitis. So for those preclinical students and people for whom paediatrics is a dim and distant memory, this is basically a cold virus that for small children, particularly under a year and especially under 6 months, can make them really very unwell with essentially airway edema. And it starts off as a coryzal illness and goes to their chest, basically. The management is primarily supportive. So you're talking about oxygen if you need it, suctioning if you need it. In fact, the child that made me think about this was a child who we had on the ward who was only 4 months, who had quite bad bronchiolitis, was in a lot of respiratory distress and actually had to have CPAP on the ward. So this is it's essentially ventilation to try and increase their positive end expiratory pressure to support their lungs while they're in the midst of this virus. I'm also going to show you one more video. I can get this to work. Then there was another child on the ward. This is in because of public health, so no prizes for guessing the diagnosis. Okay, I just wanted to wait till you'd heard that noise. Okay, so that's whooping cough. So we had a 6-week-old on the ward who had whooping cough. And again, for those of you not familiar with the immunization schedule, so as it stands at the moment, the first immunization that you get as an infant is at 8 weeks, and that includes a pertussis vaccine. And there's obviously then this critical window in those first 8 weeks of life where actually you can be really quite unwell with whooping cough. You heard that child cough and cough and cough and cough, and then you heard that, ooh, which is kind of classic whooping cough. This was exactly how this child on the ward presented. The solution at the moment to this period of extreme vulnerability in those first 8 weeks is to provide a pertussis immunisation to pregnant women in their third trial from 20 weeks on, so their sort of middle of an end of their pregnancy. Unfortunately, the woman in this case, the mother, hadn't, for whatever reason, ended up having that pertussis vaccine, and the child had, unfortunately, been exposed to pertussis and been really quite unwell with whooping cough. It's a notifiable disease. We had to speak to the laboratory about it. And the other thing in this case was that Granny was working in a lab, and so there was a question about her and whether she might have actually been the source of the pertussis and what impact that was going to have in a professional sense for her. Okay, the next child, this is my anatomy, okay? So not my favourite subject, but this is to remind me about a child that we had on the paediatric assessment unit. So this is a child, a boy, born with posterior urethral valves. So this is a congenital malformation where basically at the point where you normally have the urethral valves, they're posteriorly positioned. You get essentially an obstruction and massive backflow. So this is congenital. So lots of this is happening antenatally. Massive backflow with big expansion of the kidneys and damage to the kidney parenchyma. This child had an antenatal diagnosis of posterior urethral valves, and at the point, I mean, really as soon as he was born, and then in the period shortly afterwards, was obviously in renal failure. The reason he was in this week, so he's got a diagnosis of chronic renal failure secondary to this malformation. He came in this week because he had gastroenteritis, so a quite simple diarrheal bug that to another child would just have involved a couple of days in bed and lots of drinking diurolite. Unfortunately for this boy, because his kidneys are so vulnerable, he actually went into acute renal failure. So his kidneys, which already are working at a lower level than we would like them to, took another hit, and so his baseline creatinine, which sits around 200, which for a child, I know those of you who deal with adults, you're seeing those kind of numbers all the time. For a child, that is really very, very high, and his creatinine within 24 hours was at 500. He was transferred to our tertiary centre and actually had dialysis and will almost certainly end up with a transplant. Okay, so I'm aware that there's a couple of, or at least one paediatric oncologist, so I'm not going to pretend I know lots about this. But for those of you that don't know, so this is acute lymphoblastic leukemia. Again, a common diagnosis for children on our ward. We have a special oncology cubicle that's reserved exclusively for children with acute lymphoblastic leukemia, and I think the model with oncology is pretty unique actually compared to other subspecialties. So all children who have an oncological diagnosis in the UK will have a main centre where they get worked up in the initial phase of their diagnosis and then get the mainstay of their treatment. But obviously not everyone can go to their tertiary centre every single time they have a problem. And actually quite often we're talking about quite big geographical distances, particularly in the more rural areas. So we have a kind of hub and spoke model where the district general hospitals are supporting that tertiary centre. It's called shared care. So we'll quite often have children in. So this was a little boy who's 3, who's got acute lymphoblastic leukemia, who's in the first year of his cancer treatment. He's having quite heavy-duty chemotherapy. And as we heard earlier, one of the risks is neutropenia. So you drop the count of your neutrophils in your blood, and that makes you very susceptible to infections. He was very neutropenic, and he came in with a temperature of 39. And you don't worry about where the infection is. You need to treat with antibiotics and kind of look for the infection afterwards. And he actually had a line infection, so they have implanted lines because you're obviously needing to give them lots of medication. And he had to go again to the tertiary centre for a change of line. And then, okay, so this is not the child involved. This is a Google Images picture, but just to remind me, so we had, this was last weekend, we had a 12-year-old boy with autism who was anaphylactically allergic to nuts. He'd gone into the fridge at home. They have 2 kinds of yogurt at home which look identical, nut-containing and no nuts. Believe me, I gave him quite a lecture about this afterwards. So this boy who's 12 opens the fridge, opens the hazelnut yogurt, had a mouthful, and then described an absolutely classic. He swelled up like a balloon, he started wheezing, he was vomiting, and he was in anaphylaxis. Child came in. The parents recognised that this was an allergic reaction, but for reasons I don't fully still understand, didn't administer the life-saving intramuscular adrenaline, which is basically what reverses this process. So I've put this in, I guess, primarily for physiology. So we know, so he had a low blood pressure when he arrived. His heart rate was going very fast. You'll remember from those physiology lectures, this is basically a massive vasodilation, which causes you to drop your blood pressure because of that widespread inflammatory response. You give the adrenaline, actually it's quite a marked effect really quite quickly. His swelling went down, he felt much better. We gave him some oral steroids, and then lots of education for his family. I've put this one in just to remind me. So one other thing which I think I would be remiss not to mention based on the diversity that I told you about the population was about the challenges of communicating with people who maybe don't speak English very well or not very well or don't speak any English at all, and also thinking about a population who potentially can't read and certainly can't read English very well. I've put this in because one of the other children that I saw earlier in that terrible night where the 29-weeker who hadn't had any steroids came in, an Albanian family who had a child who I managed to establish had gastroesophageal reflux, which is a really common diagnosis in small babies. My Albanian is not really up to much, and I felt it was really important that actually I needed to do more than just use kind of terrible sign language to communicate with this family. We have a system called Language Line. I don't know if any of you who are clinicians have used it. It's awful, okay? So basically, you phone the central body, you say that you need an Albanian interpreter, translator, and then they dial through to all the people that they know on their books who speak Albanian, and then their phone rings and they're wherever they are when they pick up. And I think this woman, I don't know where she was, it sounded like she was in a supermarket, the woman that speaks Albanian in English. So then you have to say, you have to give your 2-sentence explanation. Then the woman who speaks Albanian, you hand the phone over, they say to the family, and of course mum and dad were there, so we were having to kind of duplicate everything. And just to give you a flavour, I guess, of how challenging it can be, this was a really important conversation. This was not an unwell child. And actually it was really, I think they'd come to A&E 3 times in the last week. It was really important that I was able to convey to them actually how reassured I felt and my lack of anxiety. And this can be really important. I think one of the reasons why our A&E department is so busy, of course, deprivation causes illness, but actually lots of the time you're also seeing children who aren't very unwell, but who for whatever reason either don't access primary care or don't feel adequately reassured by other people that they've seen. And that's not about the clinicians they've seen mostly. I think that's about a communication thing. So I persisted with this very complicated, like triadic conversation and felt by the end that I'd answered their questions and that actually they maybe did have some idea that I wasn't worried about this child and that they didn't need to come back. And they haven't been back for at least a week. So I feel like I must have made some inroads. So that's it. I guess I just wanted to finish by saying a bit what I said at the beginning, which is just particularly for the undergraduates. I know it's a bit of a slog at this point, but what you're learning is really relevant and starts to really come alive when you start practicing as a clinician. So stick with it, and definitely, clinical medicine is fantastic, and pediatrics especially is great. That's it.
Okay, now a pleasure to introduce Dr. Kirsty Vickerstaff, who's a GP partner and is going to talk about general practice in the remotest part of Scotland.
Okay, first thank you for what turns out to be a repeat invitation. Some of you who are at Alan Finley's retirement do may notice some similarities, for which I make no particular apology. And I'm very much getting a sense of a recurrent theme here. So I was just as worried about Hannah about speaking after all these very eminent people who clearly know a lot more about research than I ever forgot. And I make no bones about the fact that this is not an academic talk. There are no references. And don't ask me where I learnt some of this, because I won't be able to remember. I wasn't a vicar staff at college. I was a McRae. I, like Gemma, acquired a husband here, but mine was an engineer. And make of that what you will. So, that's a bit about me. So there'll be a theme here, okay? So this is the start of the theme. This is one of the hills on my drive home. As you can see, it's winter. It doesn't look like that at the moment because it was raining when I left. Why this topic? Well, I'm going to make no bones about the fact that this is an advert, all right? It's an advert for general practice. There's a bit about it being an advert for Scotland, but mostly it's an advert about doing something a bit different. And it kind of echoes a theme I can hear emerging about the fact that if you have a medical or a veterinary degree, you can do whatever you want, all right? So that's kind of where we're at. Why do I think this is important? This is the serious bit of this talk, by the way, so just stay with me for a couple of minutes. In order to fulfill our current requirements for general practitioners, half of all medical students need to become GPs, okay? Now, I've done a straw poll, and in my year, undergraduate year, I am the only GP. I understand I have some colleagues in the audience for whom that was not quite the case, but that probably is where we're sitting. Of my clinical year, and I stayed here to do my clinical studies, there were 100 of us in my intake and less than 10 of us are GPs. Now, I know Cambridge is a bit unusual, but that's not great, really. There is evidence, quite good evidence, particularly in Scotland, that medical schools aren't necessarily helping with that. I don't think that's necessarily medical schools' problems. I think some of it is about general practice as well, not promoting our specialty as being something that's a great place to work. You know, GPs have a reputation for moaning. Some of that is justified. But if you look at medical school literature, a lot of it doesn't have pictures of GPs. I know, unfortunately, that I still have consultant colleagues who perhaps aren't terribly, what's the polite word? there isn't a polite word, who aren't very enthusiastic about their students becoming general practitioners. And there are, as you will all have heard, cases of consultant colleagues actually being quite rude about GPs, particularly about their ability to actually do their job. The profession is under great strain. We've heard from other colleagues that they're in the same boat, but 1 in 4 practices in Scotland has a practice vacancy at the moment. And that's a real worry for me, because I would quite like some people to be there to look after me when I'm old. Training places are not filled. I don't know what the situation is like in England, but in Scotland we had an extra 100 GP training places this year, and exactly 100 of those places are not filled. So we're offering more places and we're not filling them. And that's in a profession that already probably doesn't train enough GPs. And GPs, the government doesn't really like us very much, and that's not different in Scotland. Okay, so why a plug for Scotland? Well, health is devolved, as some of you may be aware. So the health service in Scotland looks very different to the health service in England, particularly in general practice. We don't have commissioning in Scotland, although that might be about to change. There's no QOF. And for those of you who are GPs, that's just great. Believe me, it's absolutely brilliant. So the box-ticking part of general practice has gone away in Scotland. We have a different GP contract. We have a higher spend per head of population. Now, there are geographical reasons for that, but there is more money per person in the health service in Scotland. And interestingly, there's also more money in the social care system, which does make a difference. And we don't have Mr. Hunt. Absolutely. You have no idea. Okay, so this is another part of my practice. I can't quite remember where, but anyway, that's kind of what it looks like. Right, so this is not, I've already said this is not an academic talk. It's largely about anecdote and experience. So that's the serious stuff over. We had a mad idea, my hubby and I. So in 2002, I was on the retainer scheme in Kent. I had a 2-year-old, a 4-year-old, and a 6-year-old. And my husband came home from work one day and said, I found a black bin liner on my desk when I got to work this morning, which is a lovely corporate way of telling you you don't have a job anymore. So we had a competition to see who could get a job first. And luckily for us, it was me. And there were 2 responses to this move to the Highlands. The first was, you must be insane. And about half our relatives thought that, and the other half thought it was a fantastic idea. So off we went. We wanted to do something different, and this is an illustration of the fact that, you know, we had a colleague this morning who went to Sierra Leone. You don't have to leave the country, all right? Okay. So this is what you see if you drive from Inverness to where I now live. It doesn't look like that anymore because this road, and this is a road, believe me. Let me see if I can get this right. So this road, that's single track road. Okay, so single passing places. Yeah. That was replaced by the EU with a road that has 2 sides to it. It's great. Before our Eastern Bloc colleagues joined, because at that point this was one of the most deprived parts of the EU. But the view's great. So where are we talking about? Okay, so Gairloch is where I work. That's here. It is 70 miles from Inverness, which is here. So it's on the other side of the country. It's the nearest hospital. It's on the same latitude as Siberia. But fortunately, we have the Gulf Stream, which keeps us nice and warm. So it doesn't snow, but it rains a lot. Okay, so this is what we mean in this country when we talk about very remote and rural practice. Okay, so there's a long way from anywhere. This is the view from the front of my house. We get sunsets like this. And I put this picture up to remind me to tell you that I can tell from this picture what time of year it was. Does anybody want to hazard a guess? It's summer. Why is it summer? It's not quite midnight, but yeah, it's about 11:30 at night. And the reason I can tell it's summer is because the sun is setting over here, and in the winter it kind of sets over here at about 3:30. Okay, so let's look at some facts and figures. So this is the Scottish Government definition of remote and rural, is a population of less than 3,000 people with a drive time of over 60 minutes to a settlement of 10,000 or more. In Highland, which is this bit, so that's the Highland line, this is Highland, there is only one settlement of more than 10,000 people, and that's Inverness. So we are talking about this beige area, and in fact, big chunks of my practice here are off the scale. Okay, so we're talking about incredibly sparse populations. Maybe not as sparse as some parts of Canada, one of our future speakers, but it's in British terms, it's really, really remote and very rural. Okay, so to give you an idea, Highland here has a population of less than 250,000, and that area is twice the size of Belgium. And you compare that with Greater Manchester, which has a population of 2.8 million. Okay, so we're talking about not very many people in very large areas. Okay, so then that's my drive home from work, from one of our buildings. We have 2 buildings. So this is the practice area. We run from halfway down this body of water, Loch Marie, round this coastal peninsula and all the way up to here. Okay, so, and we encompass Loch Ewe. Does anybody know why Loch Ewe is famous? Military historians amongst you? Absolutely. Russian convoys all came out of Loch Ewe. And we don't have any patients anymore who were part of that convoy, but it's only in the last couple of years that the last one died. Okay, so it's 50 miles end to end, which is big for a general practice area. It's 720 square kilometres, which is twice the size of Greater Glasgow, with lots fewer patients in it. We have boat miles, so this island is inhabited, and there is a community on the other side of this loch, so on a really, really rubbish day, you have to put your waterproofs on and get in a boat. I try and avoid that. I try and make my partners do that, because I don't like boats. Lots of single-track road. Again, this red road is mostly dual track, apart from this section here, but these peninsulae all have single-track roads, and you could be up to 13, 14 miles on a single-track road at 25 miles an hour in the summer. We have 2,274 patients at the last count, which is really small numbers by UK standards, really, really small numbers. So in Scotland, the average GP list size per whole-time equivalent is about 1,800, and in England it's about, is it still about 2,200 in England? Yeah. So, but we've got 2 buildings, they're 13 miles apart on this main road. We've 4 doctors, 4 whole-time equivalents, 2 practice nurses, a massively experienced AMP, but the next nearest practices are both more than an hour's drive. Okay, I put this slide in partly to remind me to make sure the vets weren't getting too bored. I thought they might like to see one of their customers. Partly to remind me to tell you that there are more deer in our practice area than there are people. And to remind me to tell you that there are bits of my job that are quite different. So these guys give us a real problem. Does anybody know why? Lyme disease. So 1 in 4 ticks in my part of the world carry Lyme. I spend lots of my time talking to people about Lyme disease. And I do the occasional emergency tick removal, which is an interesting thing to be talking about. Okay, so I didn't want the vets to be bored, so there are some deer. So why is this a good thing to do? You know? So there are some professional advantages. You get to do whole community medicine and whole family medicine. We've got an incredibly resilient population who look after each other and look after themselves. So this is looking the other way from the sunset photograph. So there's my house. You can just about see the roof of the surgery. That's the secondary school. But that's kind of the way the village is laid out. And that's our main population centre. So that's a population of 500 people. And that's the biggest population density in the whole area. We have 15-minute appointments, which the GPs amongst you will regard as very generous. The average in Scotland is 10 minutes, and I believe there are some parts of England where people are consulting at 7.5-minute intervals. So we look after ourselves. We just don't like to do too much work. So we have a very different case mix from most GPs. We do all of our own minor injuries. The nearest A&E department is in Inverness, so that's a 70-mile drive. My favourite minor injury was the chap who had managed to chop the top of his thumb off with a lobster. and I did, and when he rang me, he was in a boat in the middle of the loch. And I said to him, so have you got the top of your thumb? And he said, no, the lobster ate it. So that didn't go very well. We do all of our own immediate care. So between the four of us, we probably thrombolize 4 patients a year, too far from the hospital for primary angiography. We don't see that much road trauma, but when we do, it's not very nice. Lots of medical emergencies. So we carry quite a lot of kit. So I would have thought, and apologies to my GP colleagues in the audience, I would have thought that that's what the average GP carries in their car. You know, a briefcase with a stethoscope and an oroscope and a few bits and pieces in it. Well, this is what I carry. So an immediate care kit. I no longer intubate, but I do carry airway adjuncts, oxygen, defib, ECG. In fact, I think there's another bag now because it just grows. So we carry quite a lot of kit. But it does make for an interesting skill mix. So Hannah was talking about her last fortnight. I was sitting in surgery 10 days ago. I saw a child with a sore ear. The receptionist rang me and said, I've got somebody on the phone who thinks they need you now. Picked up the phone. Story from this chap's wife. He'd been well the night before, but he was now talking utter nonsense. Wouldn't get out of bed. I went out to see him. He was clearly septic. I gave him 2 grams of high-dose intravenous antibiotics and shoved him off down the road to the hospital, where they finished his sepsis 6, for those of you who are interested. And I went back to surgery and did a repeat prescription for the pill. So you know, interesting skill mix, case mix. It also allows you to have a very nice car. Although this one is sadly deceased because it hit a deer at 60 miles an hour and there wasn't much left of the car. The deer got up and walked away. So it's not boring. It's really not boring. There are days that are boring, but in general, it is not a boring job. Right. That's another nice picture. This is the golf course in Gairloch. My brother-in-law, who plays golf, tells me it's really difficult. It's just the golf course. We occasionally land helicopters on it. That's the other reason to show you a picture of that. Okay? So, disadvantages? The nearest hospital is in Inverness. It's a long way. It's about 70 miles by road. There is a section of single track. You have to go up quite high. So in the winter, that pass I showed you with the nice wiggly road, that'll have snow on it. It's about 1,000 feet. So it doesn't have to be that cold before we've got snow at the top. We have a single ambulance. which doesn't always have a paramedic on it. And if we use it, they won't be back for 4 hours. It takes about an hour and a half in good weather, but the record is 57 minutes. So I had a patient with a suspected ectopic, no paramedic on the ambulance. This girl had a blood pressure of 50/0. So I decided I really needed to go with her, and she's fine. It all worked out quite well. It was a bit of a hairy journey. I did that most of the way because 57 minutes is going some. I mean, we're talking about averaging, you know, somewhere around 100 miles an hour to get to, yeah, it wasn't pretty. I can't remember who the ambulance technician offered the sick bowl to first. Okay. It's 20 minutes by air. So why didn't we use the helicopter, I hear you cry? So here we go. We get the Coast Guard. This is a picture courtesy of my husband. That's not him. He was taking the picture, but he's in our local mountain rescue team, and they do quite a lot of work with the Coast Guard. So you don't use helicopters because they take forever. So it's 20-minute flying time, but it takes you 30 minutes to get them to you, 20 minutes to load the patient, 20 minutes for them to fly to the hospital, and then 20 minutes to get them out of the helicopter at the other end. And I also managed to break this helicopter once, which they tell me wasn't my fault, but it felt like it at the time. So we had a field with 2 Coast Guard helicopters sitting in it, neither of them going anywhere, and we sent the patient by road. More disadvantages, access to services are pretty limited. There's us. That's it. There is nothing else. We have no counselling services. We have a skeleton community mental health team. We have the odd visiting professional, so our psychiatrist comes out to see us once a month. But in terms of patient resources, healthcare resources, there is nothing else. We fairly recently got a pharmacy, and before that we were dispensing. So opportunities to interact with other professionals are limited. So you get professional isolation. I'm very lucky. I have 2 partners and a salaried colleague, but some of my colleagues who work further north than me will be single-handed, and so they don't get out of practice much, and that's not really very good for you. VC helps. We've started to get some access to video conferencing techniques, but a bit like Sierra Leone, sometimes the technology isn't that great, and that doesn't help. Our patients don't have a choice, okay? So if you fall out with me and you have a gynecological problem and you don't want to see one of my male partners, you have a problem, and that's not great. Confidentiality is an issue. It's quite hard to ask for an appointment for the morning after pill from your mum's best friend. You know, you can be sitting in the waiting room. You don't know who's going to walk in. That's a particular problem for our young people. And we do our own on-call. Not at the weekends, but during the weeknights. And that is definitely has been an issue for us in terms of recruitment and retention. But you do get to look at views like this. This slide is to remind you to tell a story about being on call, which was, I did this particular incident on this beach. So I had a gentleman who was a visitor, so it wasn't well known to me, who decided it would be really good fun to have a myocardial infarction on the beach. And this is probably the most difficult part of our patch to get to. So I was at home in Gairloch. This is a 40-minute drive. And by the time I got to him, the ambulance crew had managed to get him into the back of the ambulance, but he had a pulse of 10, and so therefore was not thrombolizable because his blood pressure was dropping. And what you can't see from this picture is that the road is horrendous. So we decided we really didn't want to send him by road. So I'm there with my atropine. And don't ask me to describe the physiology because I can't remember. But there's this fabulous drug called atropine, which you give to people who have a low pulse rate, and it kind of helps a bit. So I'm sitting there with my syringe of atropine, dripping it into this guy thinking, where is this helicopter? Where is this helicopter? Where is this helicopter? Helicopter took 90 minutes to come. Landed on the beach, blew a beach full of sand into my boot, which I only got rid of when I hit the deer with the car. And we successfully managed to get him to the hospital. He did very well initially, unfortunately died a couple of years later of another cardiac complication, which was no great surprise, really. But it's not very often you end up giving people drugs on beaches. Okay. And rural deprivation is a real issue for us. So you heard about urban deprivation, patients who don't speak English. We have different issues with deprivation. So our housing stock is very poor. We have patients who are not on the mains water supply. We have one household who isn't on the mains electricity supply. Most folk don't have central heating. They're still using solid fuel to heat their houses. And I have a small section of the population who also don't speak English because they speak Gaelic instead. And I have no Gaelic, which gets quite interesting. And again, unlike the previous speaker who has a massive population of young people, half our practice population are over 65. That's the local free church. This is pretty much the view from the surgery. Okay, so personal issues. How am I doing for time? I'm going to run out of time. Right, I'll speed up. Personal issues. It's a great work-life balance. I go to work at 9 o'clock. I leave at 5, which is not very normal for GPs these days. I do a 4-day week, and I get 8 weeks holiday a year. That's my run. Schooling's good. Small school. It's an incredibly safe community to live in. So the other day I couldn't find my car keys. That's because they were in the ignition. I have permission to share this. This is my children. They're a lot older now and be really embarrassed by this. But my children spent most of their childhood being a bit feral. We quite often didn't know where they were. None of them drowned. So it's a very safe place to live. People look out for each other. Lots of opportunity for outdoor pursuits. So this is my youngest, who's a bit older than this now, out on a boat in the middle of a loch. Does anybody know what this bird is? It's a great skewer. So he was hand feeding a great skewer, having been fishing. Or the alternative is to feed Sammy. This is our local seal celebrity who lives in the harbour, being fed by people who've caught too many mackerel to eat. And then you can be nutty like my husband and do things like this. So this, again, is a mountain rescue team picture of a search. It doesn't quite often get that snowy, but you can do lots of things in our community. We've got lots of mountain bikers, lots of people who kayak, lots of stuff to do. And there's a great sense of community, which is, I think, something that is sadly missing from large swathes of the UK. Does anybody know what this is? I mean, obviously it's a truck. It's a cinema. So the cinema comes to you. It's great. This thing folds out, seats 100 people, brings the latest films. My sister-in-law still doesn't believe me that the cinema comes in a truck. She finds that a really difficult thing to get her head around. And again, this picture is actually not taken in our practice area. It's just down the road. But you can see the sort of scenery we get. Disadvantages, just quickly. Looking after your own family. So this is a really rubbish picture, but it's the only one I could find. So when your 2.5-year-old does this to his femur, between Christmas and New Year, you're on call, it's -4, and it's snowing, that becomes a bit of a challenge. The weather. Now, you'll notice I've only shown you pictures of nice weather. It's not like that all the time. And in fact, I went to look for a picture of bad weather, and I couldn't find one, because you don't take pictures when the weather's bad. The one I could find that was most helpful was this one. So this is Skye, the island of Skye. So that's what I can see. This picture was taken from my kitchen window. And I've put this up to remind me that if you can see Skye, if you can't see Skye, it's already raining. And if you can see Skye, it's just about to. So it rains a lot, it's very windy, it's very dark in the winter. You know, quite often in the winter, you'll have your house lights on all day. Doesn't get light till about 9:30, dark again by 3:30. You're very visible as a professional in the community. Not particularly in this photograph, but everybody knows your business. And sometimes they make it up, which is really amusing. Okay, and I've got, just to close, I haven't forgotten the vets. I don't know if there are any still here, but my favorite story about being a visible professional was the time I was on call, and I got a phone call. It was in the days before NHS 24 triaged all calls, so they would come straight to the house. And this wee voice goes, "Doctor, I need you to help me. I need some diazepam." What? I never give anybody diazepam. What do you want the diazepam for? For my cat. Thank you for listening.
Next, I'd like to introduce Professor David Armstrong, who's Professor of Medicine at McMaster University, Hamilton, Ontario, as a consultant gastroenterologist who's come here all the way from Canada to give us a talk today on the Canadian perspective of quality of care for digestive diseases.
My mic, wonderful. How unfortunate for you. So thank you very much for the opportunity to come back and visit Churchill and for some superb talks through the earlier part of the day. I've put here that I'm going to talk about a Canadian perspective. I will confess that there is a significant proportion of this that is personal, and I'll come back to that later. Since I'm supposed to be educationally savvy, I thought I'd have some objectives here and talk about the need and looking at quality. I'm going to be talking about a broad area of quality initially related to endoscopy, but that's really a paradigm for how one, I think a number of us feel we should be approaching digestive healthcare generally, and I guess it's relevant to the rest of medicine as well. So it's to appreciate the need for a patient-centered approach to evaluating endoscopy quality, to understand the need for a multifaceted approach, a multi-stakeholder input, and to look at the potential applicability of some of the things I'm going to talk about in endoscopy to other areas in digestive healthcare. So this is home, or it has been for the last 25 years. After a somewhat peripatetic start to my medical career, I finished up in Hamilton 25 years ago. So this is the bit that aspires to be an Oxbridge College. This is the faculty club where my middle son got married. This is what looks like a factory, but is actually the McMaster University Medical Center, and this is related to the GI Research Institute that does a lot of work in microbiome and actually does a lot of work in evidence-based medicine as well. So that actually was not my first foray into Canada, but I thought since I'm going to be looking a little bit at quality and endoscopy, there's actually work gone in partly in the US, and I had to talk about differences between the Canadian and the US healthcare system as a governor for the American College of Gastroenterology, and I thought I would plot Britain in the middle of that as well, because there are some similarities and differences. So Canada is actually a huge country. It's the second biggest landmass in the world. It's got an area of about 3.8 million square miles with a population of 34,000. The US is slightly smaller with about 10 times the population. And England fits somewhere in the middle. It's sort of, you can drop it in most of the provinces actually, but it's got a population of around 53 million. So there are some significant similarities, but there are also some differences. I actually read through the abstracts. I don't normally read things ahead of time because I don't normally prepare for anything, but I was actually looked at, this is I think what Kirsty had said, you can do anything with a medical degree and GPs do many different jobs, and I will confess that I did many different things and that I have a career plan that is non-existent. So I actually had a period, and my first foray into Canada was for a couple of years as a general practitioner in Labrador, which is on the east side of Canada in Happy Valley, Goose Bay, not related to Happy Valley of the TV program. Although some of the goings-on would perhaps not be out of place. This was the view as I drove in from Happy Valley to Goose Bay, and this was my successor, Michael Yong, who took over from me when I left in 1982 and is still there, and spent a couple of years as the president of the Canadian Rural Family Physicians. So he too had a wonderful time there. And this is the new hospital that replaced the old army hospital that was there when I was a GP. So you can do all sorts of things. And most of what I've done is, you see I'm rambling here. I like to show that I'm marginally erudite. So a lot of things, partly from a career point of view, but actually when I talk about some of the issues in quality and endoscopy, are really the serendipity, the occurrence and development of events by chance in a happy or beneficial way. Unlike some GPs, I moan a lot, but there are a lot of things that happen and are actually remarkable as one goes along. One of my sons is into linguistics and majoring in Russian, and he's gone way further in Russian than I ever managed. And we were discussing where serendipity came from, and I thought it was probably some classical origin, but apparently it comes from the old word for Sri Lanka or Ceylon, and it was a term that was coined by Horace Walpole in the 1700s about a fairy tale in which heroes were always making discoveries by accidents and sagacity of things they were not in quest of. So there's this great quote attributed to George Bernard Shaw, which says, "The United States and Great Britain are two countries separated by a common language." And I've sort of paraphrased that a little bit, which is that Canada and England are two countries separated by a common philosophy of healthcare delivery. So healthcare in England is delivered by a publicly funded healthcare system, and it's guided by the National Health Service Act, dating back to the 1940s, predominantly free at the point of use. Government funds most healthcare costs. There are a couple of things that are different. Physicians are salaried, I think, predominantly, and funding comes nationally from general taxation. I won't go into detail, probably because I don't understand it. But healthcare in Canada is also delivered by a publicly funded healthcare system, and there was the Canada Health Act somewhat later in 1984. It's predominantly free at the point of use, although there's no drug, home care, glasses, or dental coverage. Government funds about 70% of healthcare costs, 30% of costs for uninsured services, but patients can't be extra billed, or they can't be billed for insured services, so there really is no private healthcare. And the other thing is that physicians are paid on a fee-for-service schedule, which actually has a significant impact on the way that services are delivered. And the other thing is that funding is joint. It comes from the federal and provincial taxation. So the federal government gives money to the provinces, and then the provinces decide, thank you very much, what they're going to do with it. Don't you tell me what to do with it. And so it's determined and administered provincially, which is an interesting challenge when one tries to look at larger scale or national initiatives, because one's discussing with various bodies. So I'm going to talk about this in the context of endoscopy. I remember the first endoscopy that I did in Labrador, which was guided over the phone by a surgeon from northern Newfoundland, and he told me what to do as I was doing it. It was revolutionized because the previous one was a rigid scope, which, as you can imagine, is not a particularly comfortable proposition. This doesn't look much better. This is Basil Hershowitz in the 1950s. He used fiber optics to develop flexible instruments that were much less torturous than the things that the Germans had developed to look at the stomach. And we now have remarkable bits of kit with sophisticated lights and flexible shafts and CCD chips that transmit information back to the observer. So they're remarkable bits of kit. Indications for doing endoscopy. are basically, it's indicated when information gained or the therapy provided will help the patient, and it's not indicated when the information or therapy will not have an impact. It's common sense, really. An indication should be documented, and when it's a non-standard indication, it should be justified in the documentation. I've highlighted these because that sounds all well and good. If you have a fee-for-service system, there is another driver, which is, there's an old saw which says never ask a surgeon whether you need an operation, and you can modify that and say never ask an endoscopist whether you need an endoscopy, because just to be sure, we better do one. So there are a lot of indications for doing endoscopy, and I won't bore you with gastrointestinal medicine, although I will, to go back to an earlier point, say that physiology, such that I remember it, is actually remarkably useful and underutilized when trying to deal with gastroenterological diseases. And the challenge we have with endoscopy is we have an endoscopist, or somebody with a glove on anyway, who says, to be completely honest, I have no idea what I'm looking for in here. And it's actually disconcerting how often that is actually the case. So endoscopy, it sounds like a benign undertaking, and there have been countries around the world where colonoscopy is taken off as a way for screening for colorectal cancer. That is not looking for people who have symptoms, but in people who are well walking off the street, and you're going to them and say, we're going to do this investigation on you, and we're going to save your life. Except that there are some problems with it, which is that colonoscopy is nominally associated with a perforation rate of about 1 in 1,000 to 1 in 2,000, which suggests that you may have to go from this harmless investigation to the operating room, which is not a great option. You can get bleeding, you can get cardiorespiratory complications, and we sometimes miss the cancers. Generally, we say to people less than 5%. The data say it's probably more like 8%. So there are some challenges. Endoscopy, if you ask us as endoscopists whether we do a good job, we all think we do a good job. But actually, there are challenges. And it's a complex undertaking that has a visual motor component. We're not all as dexterous as we think we are. There are cognitive issues. Do we do the procedure for the right indications? Do we make the right diagnoses? Do we recognize what the heck we see? And again, we're not as good at that as we think. There's a problem with access to endoscopic services. There's problems with setting standards, who should, who shouldn't, how good should scopes be, and then measurement of needs and outcomes. So there are a lot of things. If one's looking to improve endoscopy, and I would argue that a procedure that causes significant injury in 1 in 1,000 people needs improvement, then there are some challenges. And so the question is, how does one approach that? And that goes back to, as it were, comparing and contrasting different healthcare systems. So England has the advantage, and I'll come back to this later, that it has a national health service. It's got a central direction, and for all the flaws, and I've heard that there are challenges. I haven't worked here for 30 years, but there are challenges. In Canada, when we were looking at how we were going to work on endoscopy, we tried to work out who we were going to talk to. So we thought about Health Canada, who are responsible for helping Canadians maintain and improve their health and have a mandate to improve quality. There are provincial ministries of health. There's the Royal College of Physicians and Surgeons. There are provincial colleges of physicians and surgeons. There's Accreditation Canada that goes around hospitals and makes sure they're up to standard. There's the Canadian Association of Gastroenterology, with which I've been involved for about 20 years. There's provincial associations. There's a Canadian Association of General Surgeons, provincial associations of general surgeons, the Canadian Association of Colorectal Surgeons, all of whom feel they've got some responsibility for endoscopy. So we talked to a number of them from the Canadian Association of Gastroenterology, and they all said that's really interesting, but that's not really part of our responsibility. So what I'm going to talk to you about over the next few minutes is some of the initiatives that have been taken on by the Canadian Association of Gastroenterology in trying to take a long-term view on how to improve endoscopy. And in that, we have worked with people across Canada, but also with other jurisdictions, and particularly with some extraordinarily helpful people from England and the NHS, where it has to be said the endoscopy service in England has been way ahead of most other jurisdictions in terms of grappling with problems with quality and endoscopy. And this is something I'm sure you're familiar with, the PDSA Plan, Do, Study, Act cycle. And this is where sort of opportunism or serendipity comes in, because there are a number of things that one could address here in this circle. We had the opportunity about 15 years ago of potentially doing something around the study area. So there are a lot of things to do, and one has to take one's opportunities where they come. So the opportunity came with study, and were we in a position to be able to measure some of the challenges. And again, I'll show you in a few slides why that's relevant. So what we had the opportunity, it's actually working with a pharmaceutical company who wanted to do something that was going to be of value to physicians, and what we did was to turn that into a practice audit program, which is a way of monitoring practice and then reflecting on it so that one can try and improve one's practice. And that goes across a number of areas. Nominally, one can do that from a chart audit or a chart review. That's extraordinarily cumbersome, and it's so daunting that most people never get anywhere near doing it. So what we thought was that it would actually be useful to have something that was electronic, where we could collect data at the point of care so that it wasn't burdensome. It was not tied in with hospital systems, because one of my banes of my life is trying to work with IT systems in hospital who know the word no and don't know much else. And so the system should also be able to provide feedback. And this is, again, is opportunism, because it came at a time when sort of worldwide web access, internet access was starting to increase so that people could get access to information easily. So we piloted this in endoscopy. So we call this the PAGE program, which is Practice Audit in Gastroenterology. And the idea was that we could record data at the time of endoscopy, upload it to a database. It would be presented there, so endoscopists could look at their data, they could reflect on it, and hopefully make some change. I got a colleague who looked at this and said, this is a feedback circle. He said, I don't like circles because you finish up where you started. I'd rather have a spiral where you get better, if possible. So those started in about 2002, 2003. We looked at upper endoscopy, colonoscopy. We looked at wait times for access to care. We had a fair number of people participated. We had, I forget what the numbers were, we had between 100 and 200 people took part in these programs. Most of them completed them, and we got data on a lot of procedures. And the interesting thing around this was the data were presented back to them so that they could review their data anonymously. And when we looked at the data again anonymously, we looked at some of the variations in practice, which is really part of a needs assessment. In relation to colonoscopy in this case, which showed that when one compared the different provinces, there were significant variations in the reported practice. Now, this is all self-reported, so people said, people may be over-optimistic about their performance. If that is the case, and it may be, they certainly were prepared to report some significant deficits in practice as well. And what you can see here is that, for example, that there's significant variations in completion rates ranging between provinces from about 80 to 95% above and below set standards. And there are variations here in terms of intubating the terminal ileum, which probably reflect differences in billing practice rather than any need on the patient's part. It's interesting. So we came up with a number of things. If one's going to try and improve practice, one is to know that there's a problem, which is what we've demonstrated, and then the second is to try and set some standards. So part of the process, again, was to try and set up credentialing guidelines, which we published as a series of recommendations about 10 years ago. The other part about improving, there are a number of other things. One is to try and improve training, and we started a local course about 12 years ago at McMaster. I had the opportunity to meet a couple of really outstanding educators and quality people from the UK. Roland Valori and John Anderson work in Cheltenham and Gloucester. And I met them at the World Congress and invited them to come to our next endoscopy course for our trainees. They invited us reciprocally to Cheltenham to watch some of the work that they were doing. And out of that came for us an annual residence training course, which we've now run for the last 12 years. And the idea is to get everybody together as a common starting point at the start of their gastroenterology training. So we bring them together, they have the opportunity to look at practice audit, and they realize as we look at these data that it takes something like 300 to 400 procedures before people become minimally competent in their procedures. They can do practice audit, and the other thing that I talked about was not only do we need to have improved skills, we need to have access to that. So another initiative that we put on here was to look at recommended wait times for access to care. I won't go through this in detail, but there was a consensus group that determined what was a reasonable wait time. And again, this was done from the basis of the Canadian Association of Gastroenterology as a professional organization rather than any of the national bodies. And what we demonstrated was significant waits to access, which is obviously a problem for access to care. And we published that about 10 years ago. And into that, about 10 years ago, the provinces started to announce colorectal cancer screening programs, which led to a significant increase in the need for resources. This is, if you like, a perfect storm with the need for quality improvement, new colorectal cancer screening programs, wait times, and a whole slew of needs that came out of that. And of course, the first cry was, what are we going to do? What's the solution? More money. And as most governments do, they said, no way. And there was a problem, actually, because when we looked at this and we looked at the number of procedures, just to summarize this, you can see that over about a 5-year period in Canada, from the red to the purple bars, there had been about a 25 to 40% increase in the number of procedures that have been done annually across the country. So arguably, money and resources were not really the problem. So this takes us back to England, and these are data. This was a problem that had arisen in England with the bowel cancer screening program, and they realized that endoscopy was a problem here. Again, without going into detail, endoscopy was the black sheep of the investigative family here in the UK, with long wait times and lots of people waiting to get endoscopy. They also had a problem with quality, and this is a survey that they did in 1998, 1999, showing that they had low completion rates, low polyp detection rates, high complication rates, and a measurable 30-day mortality from colonoscopy, with a perforation rate of about 1 in 750. So the initial approach to the NHS was give us money, and the NHS said no. So what did they do? Roland Bellori is a gastroenterologist who's in Cheltenham. He was put in charge of the bowel cancer screening program. He worked with Debs Johnson, and they set up a program across the country which is based on patient relevant metrics for quality improvement that in 12 domains, which they called the Endoscopy Global Rating Scale. And this is, again, based on a feedback loop. It looks very familiar to anybody who recognizes a PDSA cycle. And they had remarkable success with this. They got widespread adoption, and they got widespread improvement up to level grade A and grade B over about a 5 or 6 year period across the country with their units. And they had a significant reduction here in the proportion of, or the number of people who were waiting for endoscopy. Now, that's not the only thing that played into this, but setting up a quality improvement program and a framework was tremendously useful. And that, along with their education, when they repeated their audit and published it about 3 or 4 years ago, led to a significant increase in the completion rate, increased polyp detection rates, a significant decrease in the perforation rate, and a reduction in the mortality rate as well, or the associated mortality. So we looked at that, worked closely with Roland Bellori and his colleagues, and tried to set up something similar in Canada with the Canadian Association of Gastroenterology. And I'll try and run through these quickly. We wanted to look at endoscopy service delivery, endoscopy performance, training, guidelines, and a strategy to try and take us forwards. So we took the GRS that Roland Bellori and Debs Johnson had rolled out across England. We Canadianized it because there were things in there about trusts that every Canadian looked at and scratched their head, and what the heck's a trust, unless it's got money in it. And I gather most UK trusts don't have money. But the basic framework was the same, and part of producing a Canadian version was to get buy-in from our Canadian colleagues around this. We initially worked with the English website. They were very generous in allowing us to use that initially as we got off the ground, and then over the next 2 or 3 years, we set up a Canadian website. And we worked with a number of our partners, including federal organizations such as the Canadian Partnership Against Cancer, that has a tremendous interest in endoscopy quality related to colon cancer screening programs, and they adopted and endorsed the global rating scale and its use across Canada. We also set up an endoscopy recognition program so that endoscopy units that participated in this would get recognition, which they could take to their hospital administrators and turn and lobby for resources. And over the last 10 years, we've gone from 12 initial pilot sites to 163 sites across the country. There are about 450 endoscopy units across Canada. And we've had the provincial programs, national programs, and in particular the biggest province, Ontario, all of them have endorsed this as a quality improvement tool. When we initially went to them and showed it to them, they said, no, we don't need that. Once it works, they're prepared to take it up. We continue with practice audit, and that remains something that's accessible through the Canadian Association of Gastroenterology, and there's my login page. We worked on training and credentialing, and again worked closely with the model that had been developed in England. We developed what's called the C program, which is skills enhancement for endoscopy. And we have train the trainer courses, which is teaching people how to teach endoscopy, if that doesn't sound too repetitive and tautologist. And we also have colonoscopy skills improvement, which allows people who are practice endoscopists to take a one-day course and pick up on some tips and tricks on how to scope better. So over the last year, we've had 135 delegates. We have about a course a week, and these are small courses with 3 people per course. We've done 10 train-the-trainer courses, and the idea is to have our trainers able to teach our residents and trainees how to scope appropriately as well. And the next area that we've worked on is guidelines, because one of the things that's needed really, we've realized to try and affect change is to have position statements or published data that can be used to leverage change with payers and with administrators. So about 5 years ago, we had a multinational consensus conference on safety and quality indicators in endoscopy so that we could bring all of this together, publish it, and then tout it around the various ministries of health. And we tried to address a number of areas, including ethics, facility standards, quality assurance, training, reporting, and patient perceptions. And we used a web-based literature evaluation platform that we developed so that we have a grade basis for our data to try and ensure that it's credible. And we felt that this provided us with a basis then for continuing to push the endoscopy improvement programs that we were developing and to get the provincial ministries to adopt the global rating scale. And that's part of a ongoing strategy, which includes now continuing to work with national and provincial organizations to continue the adoption of the global rating scale, particularly with some of the larger hospitals, to continue with the endoscopy recognition program, because encouragement at the local level, and particularly at a staff level and a nursing level, is key to actually getting some of these changes to occur. We continue to push the practice audit, because although in an ideal world, these are data that should be available from endoscopy reporting systems, there's only about 5% of endoscopy of hospitals across the country that actually have electronic reporting systems because they don't see that as a priority. And then we will continue with the skills enhancement program and continue to roll that out so that we go from the straightforward performance of endoscopy to interventions and, for example, removing polyps. In the future, we think that this is really, and the hope is that what we've done is to establish a framework that will allow us then to move this on into other areas, whether that is in endoscopy with other procedures, because colonoscopy is only one of a number of procedures that we perform, arguably to advocate for the introduction of abdominal ultrasound into gastroenterology, because currently we're in the middle of turf wars with radiologists. Inflammatory bowel disease with Crohn's and colitis is an area that's ripe for quality improvement because, again, it's a chronic disease that affects particularly the young and those in the middle of their sort of productive life, and other areas including nutrition and malnutrition, which are a huge problem across the world, particularly for hospital inpatients. So I've given you sort of whistle-stop tour, and I would say, to echo the theme from some of the earlier presenters, if you'd asked me 20 years ago whether I would be involved in quality for anything, I would have looked you in the eye and said, there is no way I'm going anywhere near any of that. I have no idea what it involves. But serendipity is an amazing thing. I have no idea how to control it. Patience, I think, is incredibly important because a lot of these things that I've talked about, we'd actually talked about and envisaged 15 years ago. We had a checklist or a shopping list of things we needed to do, and we had to wait for the opportunity for them to happen. And we had to wait for the people who were interested in doing it, and then they could step up to the plate. Opportunism, sometimes weird things happen, and you just have to grab them before they disappear. Flexibility, you need to be able to change course. Leadership and partnership, and in particular partnership is identifying people who are wanting to go possibly not necessarily down the same road, but in the same general direction, and you can co-opt them. So I hope that I've shown you that it's important to be patient-centered because it really is difficult to argue with payers that you need to make changes if they think it's for you as a professional or for saving money sometimes. But if you say it's patient-centered, it's really difficult to turn that one down. It needs to be multifaceted because there is nothing that has a single solution, certainly not in healthcare, which is incredibly complex. You need multi-stakeholders because you need partners, you need other people who can work with you and who can deal with the other issues. And if you can get a model right, then you can apply it in other areas so that it's not a one-off. So that's sort of my history of what I think happened with endoscopy quality in Canada, and it's my history. And I found this one in a novel by Julian Barnes, which is, history is that certainty produced at the point where the imperfections of memory meet the inadequacies of documentation. So my documentation has to be taken with that caveat. And with that, I will say thank you for the opportunity of talking to you from Hamilton, which, as an industrial city that has a reputation probably comparable to what Sheffield had 20 years ago, actually has 100 waterfalls along the Niagara Escarpment and is actually a beautiful place to visit. So if any of you wishes to visit Hamilton or McMaster, it is well worth a visit. And for those of you who like wine, the Niagara Peninsula is awash with wonderful wines. So thank you.